Hey everyone, this is Fred again, and I'm joined today by a really good friend of mine, Cliff Frank. I've known Cliff for years. He's been around healthcare, very heavily involved in value-based reimbursement, ACOs, setting up unique systems, unique payment models. So great to have you here, Cliff. Why don't you give the group some of your background on what you've done over your long and illustrious career?
Well, thank you, Fred. All that means is I've gone down in flames bigger than most. I've run health plans, I've run provider networks, I've run medical groups, I've been yelled at by everybody, so it doesn't matter. And the focus of my time in the industry has really been to work that space between payer and provider to try and kind of eliminate some of the conflict and to align the clinical and financial incentives among everybody around that table so we can find interesting ways to do new things and sit on the same side of the table for the benefit of the patient.
So can you tell about what you're doing now with your firm? I know you're working with an ACO and some of the work you've done in that space.
So my firm is Healthcare Management Solutions. I've been on my own for 20 years, and I helped set up this accountable care organization, primarily first for commercial and Medicaid business with contracts with Blue Cross in New Jersey, about 250 doctors, about 50 primaries, and the rest are specialists, around one mid-sized hospital, Shore Medical Center in Somers Point, New Jersey. Subsequent to forming the commercial ACO, we hooked up with another existing Medicare ACO called Allegiance, and we are kind of our own chapter within that. And so we have about 8,000 Medicare lives for which we are also in a Track 1 Medicare ACO, and we just got bonus for 2017, which was very sweet.
Well, congratulations. So your ACO originally was, you said it was commercial and Medicaid, and how many lives do you have in that?
So we have about 12,000 commercial lives with Horizon Blue Cross in New Jersey, and that we bonused 2 or 3 times on that one. And then we have 14,000 lives with NJ Health, which is Horizon's Medicaid HMO, and we've never come close to bonusing on that. It's I think I did a bad deal, and I'm trying to rework the deal, but we weren't even close. It was pitiful.
So was your Medicaid and your commercial one-sided risk, or are they two-sided risk in those two models?
No, they're still all one-sided risk. I think the hospital CFO would, since the ACO is owned by the hospital, we don't really have a good way to recoup money from the doctors since they're not owners. So if we ever get into a two-sided risk deal, I'm really not sure how the math's going to work, other than us going out and buying some sort of reinsurance policy to cap our risk for sure.
Mm-hmm. So the doctors in this case, it's a hospital-owned ACO, and they've contracted with the doctors in that network to provide services. And are they being paid fee for service? And then how is the shared savings work?
So with ACOs, and as the ACO executive, I can only negotiate shared savings bonuses. I cannot negotiate for the town docs, for the community docs, their base contracts with the health plan. That would be a violation of antitrust, and I'm not going to jail. So everybody has their own deals, and then on top of that, we get bonus if we improve quality across 6 or 7 metrics in the commercial side. I think about 12 on the Medicaid side and 31 in the ACO, Medicare ACO. And then we get anywhere from 50 to 70% of savings depending on the contract.
And is that after hitting a certain savings percentage, and once you hit that percentage, you then
that's a really interesting point. So Medicare is weird. Or maybe they're just smart, actually. When the Medicare ACO was set up, the actuaries were very concerned that some ACO might just get lucky and get a bonus. So what they said was, you have to hit this certain, what they call a minimum savings rate. And that varies based on the size of the population in the Medicare ACO, from as little as 2% if you have like 25,000 Medicare beneficiaries, up to about 4% if you only have 5,000. 5,000 is the minimum threshold. So for us, it's about 3% because we have, in Allegiance, about 12,000 total lives. For the commercial and the Medicaids, there was no minimum savings rate. We either punch through or we don't. So that part is easier. That being said, the metrics that we have to meet, the spending metrics, are risk adjusted. And so it gets harder to kind of gain that, although I try.
And as you said, you've got essentially three quality metrics. You got the 31 from CMS, you've got your Medicaid and your commercial. Are they overlapping, or are they all completely different?
Probably 2/3 overlap. And frankly, they're not that hard. And you do one, you're probably likely to get the two more. So like you have to do a percentage of people who get diabetics who get an HbA1c test.
Right.
Well, then there's a diabetic eye exam and there's a diabetic neuropathy. Well, if you're going to do one, you're probably going to do the other two. So it's almost like a threefer. So we not always, because some patients, the doctor only gets one, but we kind of nag them, so they're pretty set up to do all three at one shot.
And is that done? Is the system with those different doctors? Do you have an integrated EMR?
No. We have about a half a dozen EMRs in among our primary care base. So a half a dozen is not that bad. We have an overlay business intelligence software from a company called Health EC.
Yep, know them.
And it works pretty well. They get a claims feed from Horizon, they get a lab feed from LabCorp, and then they have interfaced with each of the EMRs, so they can go look and find the BMI that's in the text of the patient's record. A lot of that capability we're not really using because for like the BMI finding, because we're giving the information that we're missing to the doctors. They extract it, give it to us on a spreadsheet. We put it right in, and then we know we really got it.
So you're still doing some manual processes with some of this data.
Yeah, and frankly, I know people kind of poo-poo the manual aspects of this, but frankly, that's where we've been able to get people kind of jazzed up about doing this. And that's how we're really holding people accountable. It's really hard to hold people accountable for results because there are lots of intervening variables. The patient comes in, they don't come in, they follow your advice, they're not, they take the meds, they don't take the meds. Lots of things that can go wrong. But if they're there and you get the BMI or you get the HbA1c or whatever else, I mean, you've done all the process measures correctly. And so we go in at least once a month to the doctor's offices and kind of coach them up. Now, we can do that because we don't have 900 PCPs. We got 50. And so it's pretty easy to get to them. And that's 50 PCPs across 13 tax IDs. So it's not really ugly. If we were like Delaware Valley ACO with 900 PCP, you couldn't do any of that. You'd need an army. And we've got like 5 people total for everything. So it's accessible for us. I'm not saying that the model we have is generalizable to everybody.
And when you say you have 5 people total and you've got people going out the offices, who are they? And what sort of backgrounds do they have?
Okay, so this is kind of fun because what we found is that what I thought we needed was a bunch of clinicians. That's not true. What we need is a bunch of people who are people. Because we're not going out there and sticking patients with needles or talking to patients about their depression screen or whatever else. The offices are doing that. So all we got to do is kind of coach them up. So I've got an LPN, I've got a lay person whose job is really to expedite care to specialists. So she's an old office manager, and when she knows all the back doors to all the offices. So when somebody gets 6 weeks to see the cardiologist, she'll call the back line and get them in the next day. And then I've got a manager of provider relations and data, and then I've got a diabetes educator and a mental health social worker.
And are they interacting with patients as well as with the clinics? So they're doing some care coordination and things like that?
We're doing care coordination through the doctor's office. Sometimes with the patient, mostly not. Because frankly, if we call the patient, they don't know who the hell we are. But if the doctor calls them and says, you need to make sure you go to your appointment with the endocrinologist, okay, then that makes it more sticky. That being said, our social worker and our diabetes educator work directly with the patients, and we have tried to integrate them into the doctor's offices. So at least half the time they're in doctor's offices seeing patients that day that the doctor scheduled for them. And then the other times they're in our home office seeing patients from time to time during the day.
And is that something you've done through the Health EC system where you're stratifying these patients and you've targeted diabetes and some other conditions and you're picking the higher risk ones?
Well, I'd like to say yes, and that is true, but that's not how exactly the patients have gotten to the diabetes educator or the social worker. Those are mostly physician referrals. So in that sense, we're relying on the physicians to kind of know who's in trouble.
Right.
Now, that being said, we just used the data as an example to identify, we kind of worked it backwards. We said, who's got a really high HbA1c? And we found 40 patients inside one large medical group of 20 PCPs. So there were like 40 across all of those patients. And I mean, all that practice. So it's like 2 per doc, so it's not a lot. But we said, here's their risk score, which surprisingly, in many cases, was not high. And then their HbA1c, which was 13 or 12 or 11 and a half. And we said, look, these are patients you need to do, at a minimum, you need to get an endocrinology consult. That's what we as an organization, as an ACO, have kind of said. It's not a dictate, but it's advice. Anybody who's got sustained high persistent HbA1c needs an endocrine consult.
Mm-hmm.
And so now people are kind of seeing those patients. They're also rescoring them because these patients are undoubtedly, if they've got a risk score of 1, 1.05, 1.3, they ought to be like a 17. So, these scores matter, and that's a whole nother dimension of what we're paying attention to. But here are a whole bunch of patients who are primed for comorbidity, that they probably have comorbidities that haven't been coded in the last year, so they fell off. And so we need to pick up the coding, and we need to pick up the clinical process on these patients. So it's kind of a double pop.
Right. And have you seen some changes in those numbers, improvements?
Yes. Now, separately, we are running patients who are suspect lows, or patients who have had, and this we did use the Health EC system for, patients who had diagnoses drop off. Every January around this nation, a whole bunch of patients who are diabetic amputees suddenly have their limbs grow back. because their diagnoses of amputation fell off.
No
The
pun
day,
intended.
yeah. So it's and that detracts from the risk score when those things fall off. So we have produced a list of patients who have potential diagnoses that have dropped off, or who may have kind of they're CHF patients, but they may have some other things. And here's kind of the common clusters that we see. We have then pushed that out to the doctor's office, and we're seeing about half of those patients come back so far with some sort of elevated diagnosis change.
And for the class, do you want to kind of walk through what this means? Because you're essentially getting reimbursement that's based on risk adjustment, and if they and so talk through that whole claims issue and what you're talking about, how it impacts your ACO if you don't get that.
Think of the risk score as your GPA, and some people have a really hard time in school for any number of reasons. And other people like Fred just can kind of go to sleep with the textbook under his pillow. And he wakes up and he knows everything. So if you picture kind of that friction as a measure of difficulty, we do the same thing in healthcare. So if a patient has 10 different diagnoses, they're morbidly obese, they have high cholesterol, they have diabetes, they have diabetic retinopathy, they have some sort of neuropathy, that patient is a lot riskier and takes a lot more resources and takes a lot more potential downstream costs in their care as compared to a simple diabetic. So our job is to kind of differentiate all these cases, because here's what Medicare does, and this is what also most carriers do. They say, we're going to give you a spending target. Let's say it's $800 a month, and that's kind of on average. But we know some of you have patients, a lot of patients who are sicker than average, and some of you just think they're sicker than average, but they really aren't. And every doctor will tell you, my patients are sicker, because they only remember the ones that are sick. They don't remember the ones that either don't come in or the ones that are, walking worried well, and that's all they just don't hit their consciousness. So we have to separate out those who think they're sick from those who are sick. And the way we do that is looking at the diagnoses, and each diagnosis has a certain weight. And so it's simply a multiple regression that Medicare came up with in what they call the HCC score, which I forget what HCC stands for. Fred, I'm sure you know what that is. Health cost complexity or something like that. I forget what it is. But anyway, it's essentially a way to normalize different populations so that we can compare. What Medicare does is they'll take that $800 and then they will risk adjust our benchmark, that $800 spending target that we have to beat. And if our risk is a little bit higher than average, then that we'll get an upward adjustment. So now we got to be 850, not 800. And frankly, when we're dealing close to the margin, that $50 could be the difference between us getting a bonus and us not getting a bonus. So that's how that all factors in.
Yeah, and what happens then is each year it gets refactored, and if there wasn't a claim in there, like you were talking about, to show that they have an amputation, suddenly that individual's risk score drops, your reimbursement drops. So every plan essentially at the beginning of the year is trying to ensure that they maximize that reimbursement by identifying those individuals.
Well, what you mentioned is true, especially for Medicare HMOs.
Yep.
Because the Medicare HMO premium is risk adjusted every year.
Right.
And Fred, I don't remember whether it's a rolling 2 years worth of claims or a rolling 1 year worth of claims, but I think it's a rolling 2, or maybe they just go back to the last January. I forget. But at any rate, if it drops off, then it didn't happen until the doctor recertifies it. Oh yeah, they are morbidly obese, and I'm managing that. The irony is that the more diagnoses the doctor puts on the claim, and then puts some thought into how they're managing that, then they get a 99214 or 5 instead of a 99213. So they get more money as well because they're managing more complex patients.
Correct.
So everybody has an incentive to kind of score this right. Doesn't mean they are. And we're not saying, make up stuff. It's just, if you're managing it, put it down and make sure that you get full credit for it.
Correct. And then that's helping you in terms of setting your base, what your target is to try for your shared savings piece.
Well, and then within the Health EC system, what we do is we compare doctors to each other and say, Doctor 1, you're sitting there with an average of 3.6 diagnoses per patient visit, and Doctor 2, you're at 5.3. And Doctor 1, your average risk score is 1.3, and the other guy's 1.7. And you're seeing basically the same kind of patients. There's a coding issue here. Get with the program, because we pay out our bonus adjusted PMPM. So we rank everybody by their PMPM raw, and then we risk adjust it. And if you're above the mean, you lose half your points. So we really kind of force through the bonus mechanism a attention to what their spend is, risk adjusted. And there are two ways to fix your spend. One is to fix your risk adjustment, and the other is to lower your spend. It's a lot easier to fix your risk adjustment than it is to really manage care and lower costs.
And how have you seen the response from, say, your primary care doctors versus your specialists, and what sort of issues are you facing there?
With respect to risk adjustment or overall?
Just in terms of overall, in terms of as you were trying to get this going and building the ACO.
So the specialists don't know how to spell SQP, short quality partner. They don't give a crap. The primaries didn't for a long time either. I learned a lesson really painfully. I set up this infrastructure, not the computer system, because I wanted them screaming for data rather than just handing them data and then them ignoring it. But everything else, all the people, the processes, care managers, mental health provider, diabetes educator, all that was from the get-go. No action. The primaries weren't giving us any attention. Finally, after 9 months, I'd go and say, here's the team, send us your tough cases, we'll help you. Nothing. So after 9 months of just kind of wondering why the heck this isn't working, somebody finally told me, we need a referral form. We need a fax referral form. I said, okay, the next day we had it, and within 30 days we had 50 referrals. And every month it's 50 referrals. It all came down to fitting into their workflow. I had no idea that it was a form, and a fax form at that. I mean, they couldn't pick up the phone. They couldn't send an email. They couldn't, do a text or anything else. No, they needed a form. So who knew? But then things took off pretty well from the primary care. The specialists still to this day don't really get it, except in certain high volume specialties. Ortho gets it. GI feels it a little bit because we fussed at them. And then we've got, and general surgery certainly does, and some other high volume, but even then it's sporadic. But with only let's say 30,000 members across 35,000 across all our providers, the real issue for us is trying to get more volume into the network specialists and away from the other guerrilla groups that are in South Jersey, like Rothman or RCCA for cancer, or other kinds of groups that because this is a generally not HMO population, the patients can just leak wherever they want, and they do.
And so could you talk some about that issue of leakage and how it impacts the ACO?
Yeah. First of all, there's a fine line that we have to walk. If we call it leakage and keepage, which I tend to, somewhere along the line, the Justice Department's going to get a little upset. So we have to call it kind of clinical continuity or something like that, so that we kind of dress it up a little bit. But essentially, what we're trying to do is to feed the specialists who literally operate at the hospital, or who otherwise are in our orbit. Approximately, let me back up. Shore is 10 miles south of Atlantic City. So we are kind of in our own little moat, and we're 70 miles from Philadelphia. So a lot of patients either end up in Atlantic City at Atlantic Care, which is now Geisinger, because they own them, or they end up in Philly or Virtua or some other, electromagnet type place. Often self-referred, but sometimes referred by our doctor. Lots of times referred by our doctor. So it just kind of makes things a little bit crazy. So here's the deal. A joint replacement at Atlantic Care costs 3 times what it costs here at Shore. Babies cost double. Anything in Philadelphia is triple. So, and that assumes that everybody is treating things the same. And we actually have data now which shows that our orthopedists don't cut as often as, doctors, let's say at Rothman, which is a 170 orthopod group all over South Jersey and Philadelphia. So when you add in the proclivity pop, things can be 3, 4, 5, 6 times more expensive if they don't come to us. That being said, we only have about 30 to 35% keeping. So we have 65 to 70% leakage. That's really bad.
And so these are people that are going outside your ACO network because they're allowed to. The system is, the members can go where they would like to. Some of it's internal referral outside, but it's really a critical issue that all the ACOs face because it's less coordinated potentially. You're not sure what's going on. You've got issues around cost or price. So all of those things play in. Whereas if you're trying to create a care coordination system around an entity and you have all the services, obviously if you keep it internally, possibly quality's better, costs are better, et cetera.
We will, because Shore does not do everything. Like we don't do open heart, we don't do complex cancers, we don't do intracranial stuff. We will never get below 30%. But between 65 and 30% leakage, I mean, there's a lot of dollars and a lot of cases that are going elsewhere. We have been singularly less than satisfactory in our performance in 3 years in affecting leakage. It's really hard, and I don't know whether other ACOs have really been effective in that or not, but this is a common refrain I hear around the country. It's tough.
And what sort of things have you done, to try to make the system aware of that, to work with providers? Are there any reports you're doing on those kinds of things that go back to individuals?
Yeah, we give the doctors leakage reports all the time, and who their big leaks are. We give them reports on patients that they're not seeing that they should. And it would surprise you, Fred, how many really sick people well, it wouldn't surprise you because you've seen it, but I mean, literally, people who are, seriously at risk, who haven't seen their primary care doctor in 6, 8, 10 months. I had one patient with one doctor who is no longer part of the network, who had run up $198,000 in other claims and hadn't been seen by this doctor in 8 months. And I'm just looking at her and said, what the hell are you doing? Or not doing?
Yeah, keep going.
So yeah, we use the system to identify leakage, to identify, they aren't lapses in care. Well, they might be, but at least patients for whom something's not working. And then so we serve up that data, and then we listen to the doctor's whine about how this patient just wants to go to AMI instead of our freestanding radiology center because that's where they had their last 10 mammograms and they're just not moving, this and that. So we get all these excuses. What it comes down to is this. Doctors fundamentally are not willing to fight with their patients. It's not in their DNA, and it's not in their near-term financial interest because they're scared they're going to piss off the patient and lose them. So the best they can do is to say to the patient, if it's my mom, I'm sending the patient to this doctor. You can do it if you want. Right. That's where I would go. That's about the most we can get them to say.
Yeah, and that makes some sense. Obviously we're moving to this patient-centered approach, and I've got two areas I want to sort of talk to you about that. One is, are your providers or your primary care, are they patient-centered medical homes? Are you using those kinds of models?
Ostensibly, yes. I have a pretty strong bias that I am not a fan of PCMH.
Uh-huh. And why is that?
I don't think everybody needs everything, and PCMH is really kind of a one-size-fits-all, cram everybody through a model, whether that model really fits them or not. Mm-hmm. So, I saw that at the Vermont Blueprint for Health, which was one of the early progenitors of this crap. But that being said, a lot of the primary care docs have started employing, and why our staff can be smaller, is that they have care managers or care coordinators, which is probably a better term, on their staff that are kind of not just guiding people through the referral process, but actually outreaching to patients. Well, and then CCM from Medicare and pays for that. We have a number of practices which are CPC plus. So people are getting, essentially what has happened is Medicare has helped habituate practices to do this stuff. And what we have found over and over is when the practice adopts an administrative approach, they adopt it for everybody, not just people who are toe tagged with a particular plan.
And that's a great point.
And that was the lesson, frankly, that you and I learned from the 1990s. Yeah. Was that just because a doctor is capitated for a block of patients and fee for service for another, unless they are really kind of entrepreneurial, the average doc just does the same for everybody.
For all of them.
And that's the same bad or the same good. Mm-hmm. And so we're trying to take advantage of that in our situation by now being 35,000 lives. We are a pretty good chunk of business, particularly for the PCPs. And so they have now habituated pretty much these quality scores. I mean, we got great scores, 90th percentile or better across 6 or 7 metrics last year. I mean, we killed it.
Fantastic.
The year before, we lost $400,000 in bonus because we missed 81 mammograms. Well, I swore we weren't going to have that happen again. So
that resonated pretty good with your docs.
Well, yeah, because that was their bonus money. Absolutely. So they jumped all over it. So now what we've done is it's kind of like you raise the game each year. So now the docs have really gotten good at this quality stuff. And so I'm kind of letting that roll. And we're pushing it, but we're not hounding it. And now we're piling on with risk adjustment. So now we're going after missing diagnoses, missing opportunities to upgrade or to fully capture those risk scores. So yeah, we're giving them the quality information, but then we also give them this other stuff. The other thing we've learned is we cannot give too much information to the doctors and their office staff at any one given time. They just get overwhelmed. So, I mean, we got 15 or 20 minutes, so we only talk about Medicaid. Then we come back and we only talk about Medicare. And then we come back and we only talk about Horizon Commercial. So we might be in that office 3 times in 1 month. But that way, they keep it straight. If we try and just deliver it all in one shot, it just ends up over there in the corner of the desk and it never moves.
Yeah, there's just too much going on with all this stuff. And what about the broader network? How much are you doing things around some of those issues beyond just the hospital and the doctors?
We are looking now at SNFs.
Mm-hmm.
We have enough data so we can profile 15 SNFs, and there are 6 that seem to be pretty strong. And so we are working on that process to, within the hospital, you know, when the social workers go around, kind of, well, these are the 3 that would really be tops. We're meeting a little bit of resistance with respect to that, but I think we'll get there. We have not really done much in terms of behavioral health, physical therapy, dental, other stuff that is getting charged against our buckets in some of these contracts. We got plain to say grace over, and only so much capacity. So we got lots of big eggs to crack before I go step on the little ones.
Sure. So talking about that, as you prioritize those issues, for what did you do to sort of identify where you wanted to go first, and what were some of those areas?
Well, leakage is clearly the big one.
Mm-hmm.
And within that, there are easy things to fix and there are hard things to fix. So an easy one is lab. LabCorp and the hospital. Everybody else, get them there. Why are you sending them there? Those are alien labs. We do not want them. And so we actually handed data to a couple of high leaking groups. And it turns out, you know, they have other lab draw stations in their practice. And I said, I don't care if, you know, imaginary lab is in your office. You got to send that to LabCorp because it's going to affect your bonus if you don't, because those labs cost 3 times as much as the LabCorp because they have an exclusive deal with Horizon. So we had good cooperation from 2 high leaking practices, and the 3rd high leaking practice is no longer in the ACO. So we took her out.
Push back on some of those things around quality issues or stuff like that?
Nah.
No.
I mean, they'll throw it up a little bit, and then I said, well, that's fine. We'll just deduct it against your bonus. Oh, well, we can make some adjustments.
Uh-huh.
You know, they did throw up a legitimate argument about patient convenience and therefore patient compliance. And you know, my offer was LabCorp will take over that space. Kick the other guys out and put LabCorp in. Oh no, we got, you know, which means we're getting rent under the table. So you know, we just want to, you know, I don't want to know this. Yeah, right. So, just fix it, and they have. So that's one area. So in other words, leaks that are easy to fix. Then there are leaks that are just outrageous, like this difference in cost with orthopedists. We actually presented data to the primary, showed them what the difference was, and 40% of the referrals changed overnight.
Wow.
It was very impressive. Interestingly, we tried the same with GI because there are 2 different GI groups and they have different utilization patterns. And there was about $1,000 per referral difference in cost. That didn't go so well. The data was, it was in one of the GI groups' minds either corrupt or incomplete. And so it just made that they threw up enough bluster to scare the primaries off pushing it. So now what the hospital is doing, or what the hospital's employed physician group is doing, is they're just going to hire their own GI docs. Screw it. So that's another way to fix the leakage problem, is just to hire the specialty. And you know, that's what we're doing. Because now we have with these primaries, we've got enough business downstream referrals that we can just insource that whole specialty, and boom, you know, here we go. Because most of these specialists are splitters with Atlanticare and with Cape May. So, if we get our own, we get 100% of that business instead of 30.
And so you raised a really interesting point, and it is about the data, is you've got to present stuff in essence that's pretty much bulletproof, because otherwise there's going to be pushback that says, wait a second, it's not right. I'm not going to accept that information.
Well, that's very true. And we are pretty good at asking questions of the database, but we're not clinicians. I'm not a clinician. My data guy's not a clinician. I mean, I can't even spell the word, let alone. So, when we go pull colonoscopies, to compare the cost and the practice pattern and all that, if there are confounding diagnoses or not, I don't know what I'm looking at, and suddenly, so to make the data bulletproof, it's probably better to not try to use it as a weapon, but to use it as a point of education. Tell me what this means. Tell me what else would enrich this data pull.
Right.
So that really has become our approach. Less confrontational and more educational and uplifting.
And do you have a chief medical officer or a committee of doctors you work with?
We have a committee of doctors, an operations committee that is appointed by the board, which is, the board is interesting structure. Let me start there. The board is 3 hospitals. It's owned all by the hospital, but the board is comprised of 3 hospital administrators and 9 doctors. And the doctors have 1 vote, and the hospital has 1 vote, and it takes 2 votes to do anything. Fortunately, we've never had a divided vote. That's my job to prevent that. But the hospital early on gave up control to this potential stalemate as essentially a show of good faith. And it worked well. Then within that, or underneath that, we had 3 committees that consolidated to 1. We had a quality committee, a data committee, and an operations. And we found we were talking about the same stuff in 3 different committees. We said, this is wasting too much time. So we put it all into 1. Once a month we meet. And that group has both primary and specialists on it. The meetings are, 5 or 6 out of 10 doctors show up. And that's enough, because we don't really have quorum requirements, because that committee really doesn't have the power to order anything done. That has to go to the board, which does have quorum requirements. So, but we take stuff there for them to pick apart and bounce off of. And even before we take it to that committee, we'll go to the committee chair or some other friendly doctor and say, look at this and tell us where we're being stupid. And they do with great regularity.
Great. So you talked about leakage. Other areas you decide to focus on early as possible low-hanging fruit?
So the first things we've done is to give people a list of their patients and say, are these your patients? And they'll look at it and say, I don't know who the hell that is. And I don't know. So we essentially try and kick out from either their plan, their membership panel, or from the ACO as a whole, patients who are not ours. They may have seen the doctor once, but that was 5 years ago when the doc was covering somebody else, and somehow they got stuck to them. So, we have these errant attributions. So we go after that. That was early on. The next thing is high-risk patients. Here's your list of high-risk patients. Love them better, whatever that means.
Say high risk. What do you mean by that? How did you determine that?
Oh, well,
clinical, both?
We have actually embedded in the Health EC system, they have the Johns Hopkins risk
ACG?
score. Yeah. Yep. So we use that. They also have a metric called, I forget the name of it, but essentially patients who are at what their risk is of hospitalization within the next 6 months.
So predictive indicator.
Yeah. Some predictive model. So we combine kind of those lists to say, here's people we're worried about, or here's people you should be worried about. And they'll look down them and say, oh yeah, I know that one, I know that one. Oh, didn't know that one. And then we give them claims data underneath that to tell them what's going on. And they'll look at that and say, holy cow, I had no idea this patient was going to see a chiropractor. They never told me, because there's lots of times patients don't want to share things with their primary. So,
or they're getting meds somewhere else or seeing another doctor for something else as well. All those things, yeah.
It's kind of like cheating on your wife, So they don't want to tell. So we gave them that data, and then we gave them leakage data by patient to kind of show where, and then reversed it. Here's all your patients that are going to Rothman. Here's all your patients that are going to Atlanticare. Here's all your patients who are going to, wherever, and thought you'd like to know. See what you can do to fix it. And then we give them how they're doing on their quality scores, and we give them these. And the other thing is we now have kind of ripped off the Band-Aid and just, here's everybody, and here's you. And so it's got all the names on it.
Oh,
so
wow.
Yeah. We had a policy which was the first time you do a report, it's masked. The second time, it's got the names on it.
And they all agreed to that. You said, hey, here's what we're going to do. And the committee said, that's fine. The doctor said, that's okay.
Yeah. And then the doctors, after a year, said, screw this. Just put the names on it. Forget that masking stuff.
Really?
For everything. So once they knew that we knew how to kind of troubleshoot the data, then they grew confident enough to say, let's just have the names up there.
Mm-hmm.
So we do. And that's marvelous for kind of embarrassing gently some people who are kind of bringing up the rear.
Uh-huh.
So
have you seen, you said your quality scores are great. They've come up then over time as you brought up the ones and continue to maintain the high scores for the others.
Yes. That's actually been kind of an emotionally satisfying point, is I can look to see we were at the 50th percentile 2 years ago, and now we're generally at the 90th percentile. And there's some patients, I don't know that they would have died, but there are certainly some patients who are better managed as a result of us pushing the system to get involved with certain patients who they were not.
And you saw that increase, you said, in about 2 years, that those quality
scores. It was probably 18 months, but yeah. Wow. Yeah, it was not hard after they got their first bonus check and lost $400,000 because we missed 81 mammograms.
And when you distribute that out, what's sort of the average that somebody's receiving in a bonus check?
Depends. Well, this is going to be a cute answer, but it depends on how big the bonus was.
Yeah.
So for 2016, we had a $2 million bonus from Horizon. So $1 million went to the hospital, $1 million went to the doctors, and then 60% of that went to the primaries and 40% went to the specialists. And within the primaries, it was weighted by member, but then adjusted for your quality scores and for your total cost. So the average is about $30,000 a doc.
Wow.
So some docs got like $80,000. I mean, it was fun.
Yeah.
Then for 17, we only earned about $1 million, $1.1 million, but $600,000 has to go back to Horizon because the care management fees are a loan, not a gift, from that Horizon program. So they take that back off the bonus. So that just pisses me off, but it is what it is. So then we had a net of about $550.
Mm-hmm.
So which is $275 to the doctors and $275 to the hospital. So that $30,000 was now more like $10,000.
Mm-hmm.
So it was kind of dinky. But then we just 2 weeks ago, found we're getting another $1 million from Medicare. So we'll run that through the same kind of formula. So suddenly now 2017's bonus looks pretty close to 2016's bonus, but it just came from two different sources. So, okay, I'm happy. They're happy. It'll all be good.
And you're working these three different populations, the insured, the commercial, the Medicaid, the Medicare. You said Medicaid's hard. What are you finding that makes that difficult?
Several things. One is the deal I cut was not a good deal. I'm smarter now, but I was one of their first, if not the first, and we went for an 83% of 83% medical loss ratio.
MLR, yeah. Yeah.
Instead of, I should have gone 85 or 86. So for next year, it'll be 85. But for the last 2 years, it's been 83. They give me $3 care management fees, which is like $42,000 a month. And that's what I was really looking for, was the care management fees. And after a while, I realized, we're sitting at 87. I got some of the network at 78. I got some of the network at 97. And the pediatricians are at 97, which is not usually where they belong. And the adult medicine are at 78, which is not usually where they belong. So I got everything just backwards. So we're just now beginning to get our arms around a little bit of what's going on. But essentially, I just took the money and I took the $3 and ran. I'm going to use that over on Medicare.
When you look at the pediatricians being at that really high medical loss ratio percentage, what is that? Have you sort of dug in to see what that is?
We have a bit. They have some. So first of all, the other thing that is bad with the deal, and I can't get this changed, is the large case carve out, the stop loss.
Yes.
On the commercial, any patient who's over 100,000 per member per year in spend, out of the deal. I don't have to worry about it. The 100 I have to worry about, but if it's $1 million, I only got to worry about 100. I don't have to worry about 900.
And so you negotiated that into that deal?
I did.
Yep.
On the Medicaid, it's $100,000 stop loss as well, but it's $100,000 per admission, not per member per year.
Oh yeah.
So I'm screwed. So what happens is that covers me from the premium, but then that premium gets discharged and now needs to go back and back, and they got 3 surgeries and they got this, they got that. Okay, those people are in my pool. And so I have some high cost, long running cases that, let's say now they're cerebral palsy or whatever else, they're in the deal. And then, so they're going to specialized care in Philadelphia at St. Chris or down in Wilmington at the Moores.
Yeah.
They're generally, Medicaid's not going to CHOP because New Jersey Medicaid will not send money over the river. However, they have allowed some deals with St. Chris or with the Moores for whatever reason, but not CHOP. So, which is just a well, because CHOP is expensive as hell, although they're very good. But the others are good too. But they're just not.
Children's Hospital of Philly?
Yeah, that's CHOP, yeah.
Yep.
And so we have a lot of patients, interestingly, who are getting 24-hour care at home when they could maybe be in group settings or in other kinds of more shared cost settings, but the doctors, for whatever reason, have not ordered that. They have ordered this kind of highly intense therapy and support. So, and we're spending $12 a month, member month on dental. I mean, dental emergencies are a big damn deal, and in Medicaid population, and they're getting the care in the ER, and that's of course the wrong place to get that. So anyway, there are a whole multitude of factors, but essentially the pediatricians are through the roof on the quality metric. I mean, through the roof. The vaccination rates are. I mean, they won't if the patient won't get vaccinated, they'll kick them out of the practice. So it's a big deal.
And high quality pediatric network. And so some of the issues where your contracting really is causing you to struggle with that, maybe more so than there's some utilization issues there, but pretty much it's the contract structure.
Well, it's not my contracting, of course. It's NJ Health.
Yeah.
So, but they have other pediatrician groups that are running, 78, 80%. So, I think it's this pediatric group. It's about 15 docs. They have 6,500 members. So, I mean, it's not just a spike on a few members. They're running hot on everything. So we just have to kind of, and they're quite collaborative. So I just think maybe they're being more thorough and more diligent than as compared to what was built into the base premium. I mean, one of the things I worry about is that if they're doing really good medicine and it's just costing more, maybe that's what it should be, and we should leave it alone. I mean, I don't want to earn a bonus by compromising quality. That's not what this is about. So if that's what the structure of the premium is going to require, then I'll find a way just to carve them out of the deal completely and just say, we're going to do this deal on these other doctor groups and leave them out, because I don't want to adversely affect patient care or incentivize doctors to adversely affect care.
Is that something you could take back to the Blues? Say, hey, wait a second, we got a problem.
Oh, yeah. Yeah, in fact, they have encouraged that there's another FQHC that is kind of the same situation, although they're good on pediatrics, but they're terrible on the adults. Mm-hmm. But their adult population is a lot of homeless, a lot of HIV, a lot of other complicated stuff. And so they're like 130% medical loss ratio. They said, don't pull those guys in. Pull them into a medical home program, but don't pull them into your ACO. And, you know, that's what I'm going to do. I could go back. They want me to go to some sort of full risk at some point, and I will, but I will only on a certain subpopulation of doctors, and it won't be those.
Right, right.
So that's how I'll fix it.
And how much pressure are you potentially getting, or is it internally driven to try and move further up that value-based reimbursement chain to cap or something like that?
It depends who you ask. The guy who controls our immediate survival is the CFO of the hospital. He doesn't like any of this stuff. So he would just as soon all of it go away, except when I cash the bonus check.
Is that because are they seeing reductions in inpatient utilization?
No.
No, not from your stuff.
No, because we've been very careful to focus on leakage. So whatever we take out of the hospital, we're trying to backfill with other procedures.
And was going somewhere else.
Yeah. So with 65% leakage, we got lots to backfill. So no, what we have really been trying to do is to affect things kind of at the margin. And so we may move things up or down, utilization up or down 3 or 4 points. It's not enough to that's kind of normal bounce to the hospital. So they don't really notice it, which is just fine. Uh-huh. Whereas if we were in a Medicare HMO and capitated, I mean, they'd see 40% of their business disappear overnight.
Right.
So that's not the scenario we're working toward.
Uh-huh.
Not yet.
Got it. So are there, you just did sort of a close, we're coming up on an hour here. Are there any things you would say to really focus on or to steer clear of for somebody who is looking at doing this?
Yeah, there are kind of 3 things. One is get your patients vaccinated. Oh, I mean, that's really important. Pneumovax for your seniors and for your kids, the other stuff, but I mean, it's flu shots, all that stuff. It's cheap, it's easy, the doctors make money on it, and it saves you money downstream. The second thing is see your patients more often, particularly the high risk. If you've got patients who are high risk and they haven't been seen in 6 months, get them seen, because you're saving that doctor from a malpractice claim down the road for patient abandonment.
I know I've seen from some of these, global cap guys like Hinman down here, 8.5 visits a year for a Medicare. Is that sort of what you're seeing?
Oh, no, we're not. I mean, I think that should be.
Yeah.
We have seen, interestingly, I just pulled this number, for our commercial population, we're running 4 visits per member per year, which, that knocked me over because my normal metric is like 2.5.
Uh-huh.
And I think that's probably what you're thinking too.
Yeah.
And remember, Fred, these are not enrolled members. These are attributed members. To get attributed, they had to be at least a little bit sick. So of course they're going to be seen more, or they should be seen more often.
Yeah.
But yeah, so 8 times a year for Medicare that's attributed might be just fine. I don't really know. All I know is if you've got a high-risk member and you haven't seen that member in 6 months, that's either a clinical disaster or a malpractice claim coming. So either way, see that patient.
Yep.
And then the third thing is leakage. Give doctors encouragement and data to say, don't send to these guys because they tend to take that patient somewhere else. Send them to our orthopods because they'll bring them here. Where if you send them to Rothman, they're going to go someplace else. So those are the 3 things. And it doesn't have to be complicated. You don't have to do a ton, particularly when you're just starting out. You don't have to do a ton of heavy-duty care management, getting people's faces, change behavior, load up with protocols and all the rest of it. And of course, the last one is watch your risk scores. Pay attention to them, and watch your attribution to make sure you're not getting stuck with patients who aren't doing it. Those 5 things. And a small staff can manage those things, and with some data, you can kind of find interesting nuggets to chase. There will be more nuggets than the trick is to not get buried by the avalanche, but just pick up a few, because neither the staff of the ACO nor the primaries can really absorb a ton of info, particularly when you're just getting going on the quality stuff. So you got to have a way to kind of parse it out in digestible bites.
And just one question in closing. The new MSSP pathways announcement by CMS.
This is a marvelous opportunity for some. It's deadly for others. Probably 30 to 40% the one and 60% the other. ACOs that have the 561 that have been alive as of today, most don't save money.
Right.
Most don't save money because they're owned by hospitals and they're working another agenda. That agenda is a primary care land grab, and this is just doing this as a way to kind of rope in your primary, particularly the splitters. And that's what we're doing. Those ACOs that are physician-owned and not hospital-affiliated, so they can kind of be neutral or cherry-pick, they do okay. They might be, with a capital partner, ready to step up further. These hospital-owned ones, I suspect they will bail. Have you seen what percentage, when you have to go to risk, what the downside percentage is, Fred? Has that been specified yet? I didn't see where it was.
No, I don't think it has yet.
So if it's a 4% downside risk, okay, that's on $100 million, that's $4 million. That's painful, but it might be manageable, particularly if you buy a reinsurance policy. If it's 25% down because it was 25% up, oh my God, that could put the hospital right out of business. That's not going to go. So I think it'll end up probably somewhere in between that is what the downside is. But from what I've seen, Velma is not going to back down from this. Unlike Berwick, when he put out the first ACO draft and we all vomited all over it, and then the second one that came out was way different. This will not, I predict the final version will not be much different than the initial version that we see now.
No, I think you're on target. I mean, between what we've seen now with the site of care issue, this one, some others, and some other things I've now heard through a good friend of mine who's talking to some folks at 1600 Pennsylvania Avenue, they are fairly aggressive about going after some of this stuff. So it'll be interesting to see.
It's going to be wild.
Oh, yeah. Well, thanks so much. Appreciate it, Cliff. And we'll stop the recording now.